Okay, awesome. Well, hi everyone. I'm Dr. Mehta. Nice to meet you all, and thank you for joining us today for this seminar. Hopefully, I can answer your questions about fertility and IVF. But we will have question and answer sessions at the end. If we don't get to your questions, please feel free to email us. But we will try to answer your questions as we go through the presentation. We have about an hour together, and hopefully you'll find it useful. And that's me. So first of all, I just want to talk about our mission of our company. So Kindbody, we started about 3 years ago, and our mission is to increase access to care. So we're very unique in the sense that we are partnering directly with employers, and employers are starting to understand how important family building is, how this benefit is a crucial benefit to recruit good talent, because people want this benefit so that they can build a family and they don't have a financial barrier to building their family. And on top of that, we also believe in treating the patient as a whole in a holistic experience. So we have an amazing aesthetic when you walk into our clinic. It's just gorgeous. We're trying to reduce your stress as much as we can. We have support staff, mental health, nutritionists, counselors, whatever you need to help ease your journey and your experience is near and dear to our heart. So with Kindbody, we really strive hard to make sure that you're well supported during the fertility journey. And we are not just an IVF clinic. We do the gamut of reproductive endocrinology and infertility. So if you need something as simple as just oral medication to help you ovulate, we can do that. If you need inseminations, we can do that. If you need IVF, of course, we can do that. We also have our in-house egg donor agency, frozen embryos. We have our own gestational carrier agency. We are about to launch our own genetics lab in the next few months. We also have an in-house prescription service so that when you need the expensive IVF medications through Kindbody prescription service, we give you the best pricing. If you found pricing that is cheaper somewhere else, we will match it. So we do, again, everything possible to make it easy for you. And by eliminating third party and bringing everything in-house, we're really trying to keep our costs down so that, again, financial barriers are removed for a person's quest to build a family. We also feel, and I feel very strongly that education is power. We are in this journey with you to help you build your family. I consider myself as a guide, as a physician. It is my job to educate you and to help you learn about the situations that you are facing, help you learn about your realistic expectations of what a treatment would entail, what are the odds of success, and set our goals. So education is power. When you are appropriately informed, then you can make decisions and you don't have any regrets, though I didn't know about this, or I didn't know about that. Whatever decision you make, we empower you to make it with all the information that you need. Sorry. So before we delve into the nitty-gritty of IVF itself, let's just take a little bit of time to just go over basic fertility. So in order to make a baby, the basic requirements are you need an egg, you need sperm, and you need a uterus where the baby will implant and grow. So those are the three things that we do diagnostic testing geared towards. So let's start with the egg. We are born with all the eggs we're ever going to have as a baby. So in fact, when a female baby is in the mom's uterus, she's already starting to lose eggs. So when the embryo is formed, they have many, many millions more eggs than how many end up at birth. So the eggs are constantly degenerating, and we are losing them throughout our lifetime, throughout our reproductive lifetime. So by the time you end up becoming pubertal and you have your first period, you only have 300,000 to 400,000 eggs left. And this is from 2 to 3 million when you were born. So every year that you get older, every month, there's a confluent system where the eggs are being pulled into the growing pool, and those that don't ovulate degenerate. So it doesn't matter if you're on birth control pills or not, you've never had a period because you've been on pills, or you've been pregnant many times and you didn't have periods during those times, you're still losing the egg. So whether or not you're ovulating is not correlated with the rate of loss of eggs. So for women, our fertility is finite. In your 20s and early 30s, the fertility is at its peak. After that, it starts declining, and I'll show you some graphs later. But again, there's nothing you or I or anyone can do to stop that decline in egg quantity. However, certain negative lifestyle factors can make that rate of decline faster, such as if somebody is a heavy smoker or substance abuser, or has chronic medical conditions. Some of those people may have a faster rate of decline of their eggs. So how do we check the egg quantity? And we often refer to as an ovarian reserve. So there are some basic hormones that tell us whether or not somebody has a normal egg quantity. Now, remember, this is just a quantification measure. It is not telling you if you can get pregnant, but it kind of gives you a gauge of timeline. So the FSH, the follicle stimulating hormone, the anti-Mullerian hormone, or estradiol, they're usually done when you're on your period, between day 2 to 5 of your cycle, ideally, between day 2 to 4. And these together tell us about your egg reserve. If your FSH is high, for instance, if a woman is going into menopause or perimenopause, her FSH is going to be above 20. If somebody's FSH is that high, the chances of having a live birth using their own eggs become quite low. The AMH, or the anti-Mullerian hormone, is also an excellent indicator of egg quantity. This test has the advantage that it can be done at any time of the cycle. It does not have to be done when you're on your period, and it can also be done when you're on your birth control pills. So we do not have to stop pills to do this test. A low AMH is considered to be under 1. A high is over 5. And again, it's not telling you you can't get pregnant. It just means that if your AMH is low and you're thinking of waiting 5 years to get pregnant, that's probably not a good idea. You should, consider completing your family sooner than later. The estrogen is also produced by the ovary, and it's an indicator of the function of the follicles. Those are little sacs, and I'll show you in the next slide. They're little bags of water where the eggs live. And a healthy follicle, when it's growing, should produce estrogen. So the estrogen has to be checked when you're checking FSH, because if the estrogen is too high, it's going to falsely lower the FSH. So again, all of these tests, they are not singular. We take all this information together along with your ultrasound to figure out where do you stand with respect to your egg reserve or egg quantity. The ultrasound, we can look at the little tiny eggs in your ovaries, that's called the antral follicles, and it gives us a good gauge. So if I only saw 2 eggs in your ovaries, even if the hormones were within normal range, let's say, it still tells me this is not right. In somebody that has a normal range of hormones, I should see a lot more eggs. So something is discrepant. So we do have to take all this data together to make a decision and not hang our hat on any one thing. So this is what I was mentioning earlier. This is what a follicle looks like. So a follicle essentially is a bag of water. So the black stuff you see is water, and around it are the cells of the follicle, the granulosa cells. These are the ones that produce estrogen. And when you do IVF, these cells have receptors on them that the FSH, you will take some injections, they bind to these receptors, and they help grow these follicles and grow the egg that is inside. You cannot actually see the egg because it is microscopic, but each follicle is supposed to contain one egg. And on average, we like to see about 6 to 12 follicles per ovary. The other component is your uterus and your fallopian tubes. So when sperm enters the uterus, it has to travel through the vagina, through the cervix, into the uterus, into the tube to meet the egg. So when the ovary releases the egg, it gets picked up by the little fingers, they're called the fimbria, at the end of your tube, and it sits in the tube. It's trying to travel into the uterus. The sperm meets it somewhere in the middle of the tube, and that's where fertilization happens. And that's where the embryo actually starts forming and dividing. So a fertilized egg does not enter the uterus until about 5 days after fertilization. And when it enters the uterus, it has to implant in the uterine cavity. So inside here is the lining of the uterus, and that is the carpet that receives the embryo, and it starts the implantation process. So you can imagine if there are any issues with the tubes, if there's a blockage, no matter how great your egg is or how strong that sperm is, they're never going to meet. In the same respect, if something is wrong with the inside part of the uterus, then implantation is going to be difficult. The other thing that people always worry about is the impact of age, which is rightly so. But the thing that you have to understand is it's not like your ovaries turn into dust at 35. It is a continuum. As we get older, we're losing our eggs. As we get older, the egg quality is also decreasing. So you shouldn't be afraid of that number 35. Plenty of people get pregnant at 35 and greater. But again, just something for you to know that if you're trying to have, let's say, 3 kids, and if you're starting at an older age, you're going to have a harder time having that last child. So just remember, it is a continuum. Older you are, the worse the egg quantity, the worse the egg quality compared to your younger self. So the egg quality and quantity, like I said, decreases as you get older, but we don't have a way of predicting somebody's egg quality. Every now and then we'll have a surprise in somebody we expected to have great eggs, didn't do well, and we find out in the laboratory. So when our embryologists are looking at the lab, at the eggs in the lab, sometimes they'll make notations. They'll say, oh, these eggs kind of looked granular or they look dark. So we can, from the very beginning, have a sense if things are not going to turn out the way we imagined. So until we have the eggs in the lab, we don't know for sure. But as I mentioned earlier, in general, you can expect that a 43-year-old will have a lot worse quality eggs than a 33-year-old. The other thing that happens as you get older, not only the quantity and quality decline, but the rate of genetic errors in the eggs goes up. So when an egg is dividing to ovulate and to fertilize, at that stage, there's something that happens called meiosis, where the chromosomes have to segregate. During that process, errors can happen. And as we get older, our repair mechanisms are not that robust. And these errors can then result in abnormal embryos. So for instance, a baby with Down syndrome or miscarriages, as you get older, having those abnormalities in chromosome number, that risk becomes higher. And again, there's nothing you or anyone can change to prevent that. That is luck of the draw. When that egg divides, what it's going to end up with, we don't have any control over. There are several things that can affect ovulation of that egg. And these can be tested when you have a hormone panel, when you come in for an initial fertility evaluation. We're checking various things to see, if there are any factors that can be mitigated. A very common condition is polycystic ovary syndrome. This is where women don't ovulate regularly. They can also have other issues like excessive hair growth on their body, irregular cycles. Many of them have suffer from obesity. Thyroid issues are also very common, especially in their women in the 30s. And prolactin is a hormone produced by your pituitary gland in the brain that can affect periods. The hypothalamus produces FSH and LH, which signals your ovaries to ovulate. Sometimes there can be an issue with that. And sometimes people just go into premature menopause for no explainable reason. Some of the time it can be genetic. There can be conditions that run in the family that cause premature menopause, such as Fragile X. So if there is a history of early menopause in your family, then that is something to take note of and get tested or get into treatment sooner than later, because often it will run in families. Right. So we already talked about the tubes and the uterus, and this is just a more comprehensive picture of that. The vagina, cervix transports the sperm, goes into the uterus, goes into the tubes, fertilization happens, and then it implants back into the uterus. So why do we call our periods the menstrual cycle? Because it is actually a cycle. When you first have your period, the lining of the uterus sheds. That's what that menstrual flow is, the shedding of the lining of the uterus. Because a pregnancy did not happen, that lining says, you know what, there's no function for me here, and it gets shed. But then you're getting ready for the next month, and the body is trying to see if a baby implants the next cycle. Not every egg makes a baby. So even in the most fertile person, you are not going to get 100% pregnancy rate per try. Natural fertility, even in couples that have no issues with infertility, it's about 15% per ovulation in a young woman. So what happens is the egg gets selected from a little tiny primordial follicle, starts growing. There are many eggs, if you remember the slide where we looked at the follicles. So out of all those eggs, only one usually gets selected to grow to maturity, and then it ovulates. When it ovulates, it ruptures, and then the egg comes out. All the others that were in the growing pool will kind of degenerate and go away, and then a new batch will start. So when ovulation happens, as the egg is growing, it's releasing estrogen, which is making the lining of the uterus thicker. When ovulation happens, then that follicle turns into a corpus luteum. This is extremely important because it produces progesterone. Progesterone then changes the lining of the uterus and turns it into what's called the luteal phase. This is where it can accept an embryo to implant. It cannot accept an embryo in any other phase of the cycle. So the luteal phase then lasts from ovulation until period. So if a pregnancy happens, then the pregnancy hormone HCG rescues this corpus luteum and it continues to produce progesterone, which supports the pregnancy. If a pregnancy does not happen, then within about 12 to 14 days after ovulation, this corpus luteum dies off, progesterone levels plummet, and you get a period. And the cycle starts all over again. In patients that don't have regular periods, the time from ovulation to having the period is about the same as anybody else. But what is different is their follicular phase. They take a lot longer to grow an egg, or they just don't grow an egg at all. So what are the things that can affect the tubes? So with tubes, a past infection or endometriosis can cause damage of the tube. So essentially, they can get inflamed and scarred. And once they get inflamed, especially if they get blocked towards the end, they can get full of inflammatory fluid, and it's called a hydrosalpinx. If somebody has blocked, inflamed, dilated, fluid-filled tubes, even if they're doing IVF, where they don't need the use of the tubes, they still have to have them removed because that inflammatory fluid can leak back into the uterus and affect implantation. So in order to check for these, we do a test called a hysterosalpingogram, or HSG, or we can also do something in the clinic called a saline bubble study to look at the tubes. So this is what the lining of the uterus looks like right at the time of ovulation. So this is mid-cycle. As the uterus is getting ready for the embryo to implant, we want this lining nice and thick. It's a nice plush carpet ready to receive that embryo. So this is a gorgeous pattern. We call it trilaminar. You can see 3 layers, and this is what we ideally want to see. After ovulation, it becomes a little bit more opaque. You don't see a clear trilaminar pattern and a little bit more bright, but that's okay. That is a physiologic change that progesterone causes, and it is expected. When we look at the uterus, we're looking for things that will affect implantation. And the big things that affect implantation are fibroids, polyps, and adhesions or scar tissue. So in this picture down here, you can see this big mass inside the uterus. Most likely it's a polyp, but sometimes it can also be a fibroid. But the good news is it's easy to remove. We can just go through the cervix into the uterus with a camera and remove it, and it's not a major surgery. Fibroids are muscle growth. So polyps is soft tissue. Fibroids are tougher, they're harder. They grow from the muscle of the uterus, and they can be in various different locations, but the ones that really impact fertility are the ones that are located inside the cavity, or those that are pushing into the cavity, or just large ones that are just distorting anatomy in general. You can also have abnormal shapes or variety of variants of normal. These here are abnormal. A septate and Asherman's is when there's a lot of scar tissue in the uterus. It usually happens after DNC, and then a patient develops scar tissue. A septate uterus is where there's a wall of tissue inside the uterus. This wall of tissue, it could be just minor, or it can go all the way down to the cervix. It is associated with recurrent miscarriages because this wall of tissue does not have a blood supply. So if an embryo implants on there, it's not going to have a blood supply and it will miscarry. A bicornate uterus is a different shape of the uterus where the 2 horns are very prominent. Most of the time, people do okay, but they are at risk for preterm labor with a bicornate uterus. Let's switch gears to sperm health real quick. So, the sperm is 50% of the equation. It needs to fertilize the egg in order to make the embryo. The easiest way to check male factor is to check a semen analysis. In a semen analysis, we are looking for the count, the motility, the shape, and the volume of the ejaculate. So all of these put together give us something called a total motile count. So if a person's total number of moving sperm in the ejaculate is very low, then probably not enough sperm is reaching the egg. It takes millions of sperm to fertilize one egg. So, sperm factor can be quite common. About a third of the time when a couple has trouble getting pregnant, there is some male factor. Women are so proactive, and nothing against our men, but women are more proactive and are ready to get all the testing done. Oftentimes we see that the partners are dragging their feet, but the reality is that because they feel great, they don't think there's anything wrong with them. But even in a perfectly healthy man, they can still have issues with sperm. And that's why it's very important to get tested early so that the female partner is not going through all of this and then to find out, oh, it was the male all along. This picture shows you all the variations in the sperm head, and that's called the morphology. This is probably the least important parameter. Most men in the strict criteria have less than 5%. 5% is supposed to be the normal. A lot of them will have less than that and still have perfectly fine fertility. Other thing is that with the sperm morphology grading, it's very subjective. It's based on who's looking. So if you take several andrologists together and tell them to grade the morphology, you will get widely different answers. But the count and the movement and the volume, they are quantifications. So those are probably the more important parameters when predicting fertility. Other tests that we can do in men is something called DNA fragmentation index. This is very, very controversial, and still the jury is out whether or not it's useful to figure out whether somebody can father a child or not. But that is something we do if we're scratching our heads and, out of options. Otherwise, the CAP score also gives us an assessment of the sperm's ability to penetrate an egg. Pyospermia refers to if there is an infection in the sperm, if there's a lot of white blood cells. We can also check the male hormones, their genetics, test them for infectious diseases, check for blockages in the vas deferens, which is a tube that allows the testicle to send sperm into the ejaculate. And we can do an ultrasound, a scrotal ultrasound. And at Kindbody, we do have in-house urologists that can do a full evaluation of the male. So again, keeping everything under one umbrella. But when we find a problem, we have many things that we can do to evaluate the male to figure out if there's something that's treatable, or if it's not treatable, then what are our options? For women, just as any other doctor's visit, we want to make sure that you are healthy to carry a pregnancy. So we do want our patients to be up to date on their pap smears and their breast exam to make sure that when they are pregnant, they're not going to face any issues with surprise finding of cervical abnormality that needs a procedure. You certainly don't want to do cervical procedures when you're pregnant to treat abnormal pap smears. We also, don't want to make sure that somebody doesn't have a thyroid issue or they don't have diabetes before they get pregnant. So we are doing everything we can to make sure not only do you get pregnant, but that you have a healthy and successful pregnancy. Infectious diseases screening is mandatory on a patient and their partner, because the embryos live in the IVF lab with other reproductive tissue. So we have to make sure if there is infection, then we need to keep them in a separate tank. We also recommend genetic carrier screening. This tells you if you are a carrier of conditions such as cystic fibrosis, Fragile X, muscular dystrophy, that can affect your baby seriously if both you and your partner carry the same condition. We also check for immunity to chickenpox and measles, because if somebody is pregnant and they get these infections, it can cause birth defects in the baby. So genetic carrier screening, just real quick, if a mom and the sperm source carries the same condition, then there is a 25% chance that the baby will not have it at all. 25% chance that the baby will have the disease, and 50% chance that the baby will just be another carrier. And, this is complex, like genetics, which you probably don't want to hear about right now, but just know that for genetics carrier screening, it is really important, because let's say if both mom and dad carry cystic fibrosis, there is a 25% chance that their baby will be affected by the disease. And, that has a lot of morbidity associated with it. Same with muscular dystrophy and Tay-Sachs and, so many other conditions. So it is a good idea to have this checked before pregnancy happens. Other things that can affect fertility is our weight. So I'm not, truly a fan of the BMI index, but that is what we have to go by at this stage. But obesity is an epidemic in the developed states and developed countries. The normal BMI is supposed to be less than 25, which a lot of people are above that. For IVF, the BMI has to be under 40 because of anesthesia risk. It's an office-based procedure, and somebody's BMI, if it's over 40, they cannot go through office-based anesthesia because it is too risky for their health. So if somebody is undergoing IVF and they have a BMI of over 40, then they're going to need to lose that weight before IVF can be initiated. With Zika, we don't hear about it as much, but the CDC always has guidelines on and travel advisories. So if you're going to travel outside the country, it's always best to take a look at the CDC website and see what their Zika guidelines are at this time. With nutrition support, vitamins, prenatal vitamin is extremely important to take before initiating the process of pregnancy. Folic acid prevents spinal cord birth defects. So if at a minimum, if there was one supplement you want to take, it's folic acid, and most prenatal vitamins do have the required amount of folic acid in them. I am a huge believer in just clean eating and minimally processed foods. Eliminate plastics, that could be a whole another talk of itself, but essentially whatever you can do to clean up what you're exposed to and what you're putting in your body is going to be important for successful fertility and healthy pregnancy. Another thing that's important to consider is, what is your family vision? Your age, how many children do you want? If you're single, do you want to just freeze your eggs? How quickly do you want to get pregnant? Do you want to start with simple stuff first? Or do you want to do the full shebang, go with IVF, freeze embryos for the future, so that when you're older, you have your embryos that you froze previously to use, as opposed to if you're 40 and you had your 35-year-old embryos, you would have a much better chance than when you're 40 and you're trying to go through IVF. So there's a lot of things to consider when you determine what treatment is going to be best for you. And that is a discussion that your physician and you would have. So for all my patients, I always try to get a clear understanding of what their goals are, so that I can counsel them accordingly of what would be a good plan for them. 1 in 8 couples experience fertility. So infertility can be a very, very lonely condition. People are embarrassed. They don't want to talk about it. People are asking them, "Oh, when you going to have your baby?" And you just don't know what to say. But know that you are not alone. 1 in 8 couples have trouble getting pregnant. And as I mentioned before, 1/3 of them are because of male factor. And infertility, either it's more prevalent now or we just know about it more, but there are so many people that need fertility services. Many of them don't talk about it. You get your invitation to the baby shower, but they're not telling you how they got pregnant. So it is very, very common. Don't feel alone if you're going through this. So now let's talk about IVF. What does IVF involve? IVF stands for in vitro fertilization, which literally means fertilization in the lab, in a glass petri dish. So every month, like we talked about, your body recruits 1 egg to ovulate. And if it fertilizes and implants, then it can make a baby. But not every egg can make a baby. Not every egg is competent to result in a pregnancy. So for IVF, we don't want just 1 egg. We want to grow multiple eggs, whatever is there in your ovaries that we can safely grow. But if someone has, like, let's say 30 eggs in each ovary, we don't want 60 eggs. That would be hyperstimulation. Ideally, we're aiming to get 10 to 15 eggs at IVF, if that's possible. Some people will get less eggs. Some people will get more. but ultimately it's the quality that matters. I try not to hang my hat on the exact number of eggs. I've had patients with even just 3 eggs, have them all fertilize and get 1 embryo and get pregnant. So while we have to set realistic expectations in this field, we never say never. So in order to grow those multiple eggs, we do have to administer hormone injections. So typically, the injections last for about 10 to 14 days, closer to the 10-day range than the 14-day range. You're taking them daily, every night in the skin of your tummy. We make sure you are well prepared to inject. If you're not comfortable, a partner or a friend can do the injections for you. But these circulate through your bloodstream, and they are then acting on those FSH receptors in your ovaries, like we mentioned very early on, and they're getting those eggs to grow. Your body makes only enough FSH to grow 1 egg. But with the injections that you're taking, you're overriding the system and getting multiple eggs to grow. And we have videos that will show you, or we'll send to you for injection teaching. We also have weekly medication teaching sessions, and people can get on these med teach sessions, and one of our nurses will be leading the class and going through the medication teach instructions in detail. So once the eggs are ready, so when you're taking the injections, you'll come into the office every couple of days for ultrasound and blood work to monitor the eggs, make sure they're growing properly, see if we need to adjust the medications. We look at every patient that comes in every single day. My nurses and I go through every single patient about midday. Once we have all the results back, we discuss every patient, how much more medication do they need? Do we need to change the dose? And then we let the patient know. So once the eggs become mature and they're ready for egg retrieval, then that's an outpatient procedure that happens in the office. It is under anesthesia. At our clinic, we use anesthesiologists, and they will make you very comfortable. It is not full-blown anesthesia where you're not intubated. You're still breathing on your own. You get some IV medication that makes you very sleepy. We put an ultrasound in the vagina, insert a needle into the ovary, and get the eggs out. The whole process takes about 15 minutes or so. Then you're in recovery for about 30 to 45 minutes to make sure that you're awake and alert, and you can go to the bathroom, and then you can go home. You cannot drive yourself home, though. Somebody has to take you home, a family member or a friend, because after sedation, it's kind of like drug driving. You can't drive yourself home, and we won't release you to an Uber driver. So you need to have somebody come pick you up. On that same day, also your partner, if you have a partner, will give us a sperm sample, and we'll process it to fertilize the eggs. Or if you're using donor sperm, we would thaw the donor sperm and use it. There are 2 ways of fertilizing the eggs. One is called just traditional IVF, where we let the sperm and the egg hang out in the IVF lab, and we just play some music in the background and let them do their thing. The other way is called ICSI, intracytoplasmic sperm injection, where we take the sperm and we inject it into the egg. We usually do ICSI if there's some issue with the sperm, like there's male factor, especially in cases of severe male factor. Sometimes we'll also do it with unexplained infertility, or if someone has opted to do the CAP score and the CAP score comes back low, then we know that the sperm is not able to penetrate the egg naturally, then we need to do ICSI at that point. Once the sperm and egg DNA is combined, then they form your embryo. So on the day we retrieve the egg, they get put together with the sperm. The next day, we find out how many fertilized. The fertilized eggs are then grown into the laboratory. And then when they get to 5 to 7 days old, they're the blastocyst stage. And at that stage, they get frozen. So people always ask, how do I know if my embryo was healthy? So when we have the embryos in the lab, we grade them before we freeze them. So the grading is based on what does the embryo look like. So it's pretty much a beauty contest made based on certain scientific parameters. So embryo with a higher grade is thought to have a higher chance of implantation than embryo with a lower grade. But that being said, the grading does not tell us if the embryo is genetically normal or not. Sometimes even abnormal embryo can look beautiful and it won't implant, or it'll miscarry, or the baby will have an abnormality. A way that we can test the embryos to see if they're genetically normal or not is called pre-implantation genetic testing. This is where, from this outer layer, our embryologist will take a few cells and send it to a genetics lab. The embryo then gets frozen. So pre-implantation genetic testing for aneuploidy, it's called PGTA. It tells you about chromosome number. If somebody carries a specific mutation, such as cystic fibrosis, like we talked about earlier, we can test the embryo and we can do a genetic screen to see if that embryo is normal, is it a carrier, or is it affected. PGT-SR refers to something called segmental rearrangements. So the normal number of chromosomes in an embryo should be 46. 46XX is a girl, 46XY is a boy. Anything outside of that is abnormal. When a normal embryo is implanted, you have about a 60% or so chance of getting pregnant. Even with implantation of a normal embryo, it is not 100% chance of getting pregnant because there are many other factors that affect fertility, but about 60% is pretty darn good. Remember, one egg per cycle at best will have a 15% chance of implantation. So by the time you get to an embryo, those odds are much, much higher. So who do we recommend genetic testing for? Anybody who wants to do it can do it. But remember that there are limitations. It is not 100% accurate. It is probably, depending on which lab you go to, on average, considered about 97% accurate. And again, different labs will have different stats that they quote you, but it is not 100% accurate. Secondly, it has not been shown to improve pregnancy rates per cycle in women that are young, under 35. It has been shown to improve success rates per embryo transfer in women that are older because they have a higher risk of abnormal embryos. If somebody has gone through multiple IVF cycles and has not achieved a pregnancy, it's probably a good idea to do genetic testing so we get more information on those embryos. It's possible that they're never making a normal embryo or there's some other issue with the embryos. So that's probably a good idea. Oftentimes people that have unexplained recurrent miscarriages will do genetic testing so that when an embryo is transferred, at least we know that the embryo that went in was normal. And then for the PGT-M, if there is a family history of a genetic disease or the patient or their partner or both are carriers of a genetic disease, we can do PGT-M to make sure that the embryo does not carry the same disease. So the benefits of PGD is you know whether or not your embryo has normal number of chromosomes. If you wanted to know the sex of the embryo, you would know that. And it can also, especially in the older women, increase the chance of pregnancy and reduce the chances of a miscarriage. The reasons why people may not choose to do PGT is because it is invasive to the embryo. We do have to biopsy the embryo and take a few cells. The chances of damaging the embryo are very, very slim in experienced hands, but still it is a manipulation that's being done to the embryo. It is also an added expense. PGT can cost $3,000 to $5,000 depending on how many embryos you have. And also, the embryos do have to get frozen. We cannot do a fresh embryo transfer with pre-implantation genetic testing. So does every egg make a baby? No, we already established that earlier in this talk. So if you see about, let's say, 12 follicles on sonogram, and we retrieve them, let's say about 10 of them were mature, we hope that at least 70% of those eggs will fertilize. So out of 10, you now have 7 embryos. Depending on a person's age and the quality, you'll have 30 to 50% of them grow to the blastocyst stage, which is at day 5 and above of development. So out of your 7 fertilized eggs, you now have 2 to 4 blastocysts. Then if you choose to do genetic testing, you may have none, or you may have all 4 or something in between to be normal. When a normal embryo is implanted, then you have about a 60% chance of having a successful pregnancy. So you can see that drop off in chances of having a baby. If you to keep the number simple, had 10 eggs. So in people that want several children, if they do PGT and they know how many normals they have, they can then make the decision whether they want to do more cycles to freeze more embryos, so that they know that, hey, if I have 4 normal embryos frozen, I'm sure that I should be, I should have a pretty good chance of having 2 children. So those are all the decision making that goes in deciding what treatment options are best for a couple. So fresh embryo transfer versus frozen embryo transfer. So most of us have gotten away from fresh transfers and favor frozen embryo transfers, just because studies showed that pregnancy and implantation rates seem to be better with frozen embryos, because the uterus has not been bombarded with all these hormones. There hasn't been so much flux, and it's more controlled. The lining, there's something called endometrial advancement, where in a stimulation cycle, the progesterone can start rising and make that uterus not in the right implantation phase. In frozen cycles, we have a lot better control, and especially with more and more people planning to do pre-implantation genetic testing, frozen embryo transfers is more common now than it was about even 5 years ago. So the frozen embryo transfer does give the patient time to recover, because it does not happen until the cycle after the egg retrieval. So it gives the woman just time to recover from all those shots and just take a breather. And as I said, it allows us to have more control to sync the timing of embryo transfer to when the uterus will be most receptive, and gives us time to get the results of the genetic testing. So this is a sample calendar for your frozen embryo transfer. There are many, many different protocols. This is a simple, straight up protocol where once a woman starts her period, she starts taking estrogen. The estrogen helps her grow the lining of the uterus. It also prevents her from prematurely ovulating on her own. When the lining is ready and when it's thick enough, and we determine that by an ultrasound, she then starts taking progesterone injections. A week later, we transfer the embryo, and 9 days later, we check the blood work to see if a pregnancy occurred or not. So a frozen embryo transfer is very, very easy. For the actual embryo transfer procedure, you do not need anesthesia. It is under ultrasound guidance. Through a transabdominal ultrasound, we guide a catheter into the uterus. Once the catheter is in the right place, either the physician or the embryologist will push the embryo into the uterus, and we will watch it on the ultrasound, kind of see that little bubble of fluid going to the uterus, and then the catheter is removed. The woman can go home right away, and there's no restrictions really. We just recommend that you probably don't want to run a marathon that day and just take it easy. But other than that, life goes on as normal. And 9 to 10 days later, we find out if a pregnancy happened. So various treatment options and success rates for medicated cycles using insemination or timed intercourse. We're looking at about 10 to 15% chance of success per ovulation per month. With IVF in general, with all age categories, we're looking at 40 to 50% success rate. With genetic testing, it's higher because we know that a normal embryo has been implanted. In the older age categories, your IVF success rate will be a lot worse. In the younger age categories, they're better. Women over 43 have typically with their own eggs much, much lower chances of getting pregnant. The IVF in a 35-year-old with one cycle, and again, this is all women pooled together, is about 41%, 2 cycles, 60%, 3 cycles, 72%, 41 years and above, 1 cycle, 19%, 2 cycles, 31%, and 3 cycles, 40%. And these statistics are taken from SART, Society for Assisted Reproductive Technology. It is a website, sart.org, and you can go on there and look at national statistics. So with the fertility journey, sometimes it can be difficult. Sometimes you hit curveballs. You think a certain thing is going to work, but it doesn't. It works temporarily, but somebody may have a pregnancy loss. So there can be many hurdles to cross, but we believe in supporting you in every step of the way. We are here for you. I, for one, don't give up easily if the patient is willing, and I will keep searching for strategies until it comes to the point where if treatment is futile, then I will be the first to let my patient know that it's time to move on. But we have at Kindbody mental health, wellness support, and also nutrition support for whatever the patient needs. We also do have our own donor egg and surrogacy services in-house. So whenever somebody is not able to get pregnant using their own eggs, they would need an egg donor. If they don't have a male partner or in a same-sex relationship, they may need donor sperm. For donor sperm, we work with national sperm banks. And then also donor embryo can be considered, where embryos have been donated by other couples that have completed their family, and they can be adopted by couples wanting to adopt them. A gestational carrier is somebody that will carry the baby for you. And there are scenarios where gestational carrier is used is if the patient herself has health conditions that make pregnancy dangerous for her, or she doesn't have a uterus, or has had recurrent miscarriages that have no explanation. Those are some of the situations where a gestational carrier can be used. With a sperm donor, it can be a known donor or from a sperm bank. There are certain tests that we have to do if it's a known donor, which means that the donor is somebody you know, is a friend. We do have to still do FDA infectious diseases testing to make sure that they are safe to donate your sperm, and some legal requirements have to be made. For egg donors, we have our own egg bank, and we also have donors that can be utilized to do a fresh IVF cycle for a patient. That's called fresh egg donation versus frozen egg donation. And having our Kind EOS egg donor agency, we are, again, trying to keep costs down by not having a third-party agency that will charge you all these extra agency fees. Same with embryo donation. With a gestational carrier, if, of course, yourself would be the first choice, but if that's not possible, you would choose somebody, a surrogate from an agency. And then some same-sex couples will also plan to do reciprocal IVF, where one partner is the egg donor and the other partner will be the carrier of the pregnancy. So I know this was a lot of information, but long story short, treatment decisions are individual to the patient's own situation and to their family vision. And us as physicians, is our job to educate you and help come up with a plan that suits your particular needs and walk that walk with you. So Kindbody has many clinics now across the country. Our Dallas office is scheduled to open December 7th. We're hoping there's no delays, but we are opening our doors December 7th. And for anybody on this webinar that is a self-pay patient, meaning that if you do not have insurance, we do have some discounts, and you will get an email in your inbox tomorrow to tell you about these discounts. So I would love to take questions.
Thank you, Dr. Mehta. We do have some questions that were sent in the chat. So I'm just going to start off with this one. They're all great. I'll start off from the top. So someone said, our embryos are frozen and are in a non-Kindbody facility. What is the risk to the embryos during this transfer process from one facility to Kindbody? And 2, do you offer polyp removal surgery?
Yeah, absolutely. So there is minimal or almost no risk of moving your embryos. That's done all the time. It does have to be done. If it's not local, you do have to use an agency to ship your embryos, and it's done in a cryo tank. We just have to coordinate with the lab that's sending them and our lab, and we will do all the paperwork for you. So you just have to fill out some stuff, and our embryologist will coordinate with the other embryologist and arrange for shipping. So that is not anything to worry about or a reason for stress. And then what was the second question?
The second question is, do you offer polyp removal surgery? Yes. And 3, what is the wait time to start frozen embryo transfer after polyp surgery?
Yes, polyp removal surgery is hysteroscopic, and that is probably one of the most common surgeries that I do. And it's very, very easy. So yes, a polyp removal surgery is easy breezy to schedule and take care of. Once that's done, you have to wait until the next menstrual cycle to do a frozen embryo transfer, unless if somebody's on birth control pills and they do the polyp removal surgery while they're on the pills, then as soon as the surgery is done, we can stop the pills and immediately jump into a frozen embryo transfer cycle.
Amazing. Thank you. Another question we have here is, are there medications that can improve egg qualities?
That is a good question. So, nothing can change the impact of age on egg quality, but there are certain medications that can help. So my favorite supplements are, other than the prenatal vitamins and folic acid, are coenzyme Q10, CoQ10, that helps the mitochondria, which is the powerhouses of the cells, and it can make the quality better. I also like omega-3, which is fish oil, which is just really good for sperm health and for egg health. And then really a clean lifestyle, clean eating, eat organic, don't use plastics in the microwave, drink water from metal bottles or glass bottles. You want to avoid all these environmental toxins that can cause a general state of inflammation in your body and affect your ovaries as well. So, but if I had to choose supplements, I would choose the CoQ10 and the omega-3 in addition to the prenatal vitamins.
Thank you. And another question we have here is, does hookah smoking also contribute to negative effects on egg quantity and fertility issues?
Yes, so smoking in general, and even with the hookah, it does have some nicotine and other substances that go into that pellet. I mean, they are not well studied, but you once again don't want to take a risk. Like even when people vape, there are so many other volatile substances that are in the vaping, which sometimes it's actually even worse than smoking. And the hookah especially, there is no filter either. So if you're trying to get pregnant, I would recommend avoiding things like that altogether.
Thank you. Another question we have here is, what's a good age to consider freezing eggs? I've completed ovarian reserve labs over the last 2 years, and they've been healthy results, and I'm 32.
32 is actually a great age. So there was a study that looked at this very thing about the cost effectiveness of egg freezing based on a woman's age. And the conclusion was that, and this is again just pretty much intuitive, the younger a woman is, the better the odds of those eggs resulting in a baby. So the younger you are, the better. egg freezing was most effective in women under 37. So if you're 44, egg freezing is probably not something that is recommended. So women under 37 have the best prognosis. But again, even with that, the younger you are, the better.
Thank you. Another question we have here in regards to the IVF injections is, do they sting, burn, or hurt?
It is an injection, and unfortunately, yes, but they're not as bad as you would think. I mean, trust me. Let's see, my oldest is now about to be 21. I had to take these injections when I was trying to conceive him. Even as a doctor, I was scared. The first time I took that shot, I was scared. But once I did it, I was like, oh, this was a piece of cake. This wasn't as bad as I imagined. So I think the buildup is worse than when you actually take the shots. But the needles are very tiny. One of the shots that you take called Menopure, it can sting a little bit. But when we send you our prescriptions, we send you a really nice little ice pack and the injection kit to help minimize your discomfort.
Thanks. Another question we have here is, through this process, can my husband and I still have sex, or do we avoid it through this process?
No, absolutely not. You can have intercourse, but when you're going through IVF, as your eggs get more developed, your ovaries will become larger and intercourse can get more painful. So as you approach your egg retrieval, we usually ask you to abstain for a few days before and a few days after the egg retrieval, because especially you don't want those large ovaries to end up twisting on themselves. So that is the only time we would, say just refrain from sexual intercourse.
Thanks. Another question we have here is, do you ever implant 2 embryos to make sure one sticks?
No. So one baby at a time is the way to go. A twin pregnancy is probably the number one reason for neonatal ICU admissions, cerebral palsy, growth issues in babies, premature labor, preterm delivery, a lot of issues. So, you see all those happy stories with twins. There are probably 3 times more unhappy stories of complications with twin pregnancies. So in a young woman, especially with genetic tested normal embryos, we only implant 1. Now, if a woman was older or has had multiple failed cycles and those embryos were not tested or of poor quality, we may consider 2. But if it's a beautiful embryo in a woman that's under 38, we follow ASRM guidelines and implant only 1 embryo.
Thank you. And then another question we have here is, do you transfer abnormal embryos?
If somebody has a completely aneuploid embryo where it has multiple abnormalities or an abnormality that's not compatible with life, then we do not. If there's really no point of doing pre-implantation genetic testing if you did not want that information and want to use it. But there is something called mosaicism, where the embryos have a mixture of normal and abnormal cells. And again, there's a lot of debate on whether or not you should transfer mosaic embryos, if it's a low mosaic or a high mosaic. So that's a complex discussion. But short answer to that is that for mosaic embryos, after having a thorough discussion with the patient, if they want to transfer those, then we will. But the completely abnormal embryos, we will not.
Thank you. And then we have another question here. What do you recommend to try to get pregnant naturally? I am 35. My husband is 38. We both want a child. We don't have children yet. We have been trying for 7 months.
Okay, great. So, 7 months is not that long, but the recommendation is in women that are over 35, if they have been trying for 6 months or greater, they should at least get an evaluation. And this is just because if there is an issue, you want to find out sooner than later and correct it before, you've been trying for 2 years and now you're 37 or 38 and your odds are lower. So, and it doesn't cost that much to get an evaluation. If someone has insurance, they usually are just subject to their copays and deductibles, but at least you have that information. And if something's wrong, you have the opportunity to do something about it. And as I said before, that education is key. even when you find out whatever the issue is, if you decide, you know what, I'm just going to try naturally, that's entirely your prerogative. But at least you made that decision informed. So if you're 35 and you've been trying for 7 months, I would recommend at least get an evaluation. And if everything's fine, fabulous. You can make that decision to try longer. So in general, in couples that have no issues getting pregnant, after a year of trying, 80% will be pregnant, and after 2 years, 90% will be pregnant. But these stats are based on women under 35.
Thank you. Another question we have here is, can you do PGT on a frozen embryo? Thaw it and freeze it again?
Yes, we can, and I've done it many, many times. We don't recommend it ideally, just because then the embryo is going through multiple manipulations. But yes, it can be done. I've had many people get pregnant because, they got pregnant before, they had frozen embryos that weren't tested. Now they want another baby, but this time they want to check and make sure the embryo is normal, or if they want a boy or girl and they want to see what the embryos are, they want to do it. So yes, we can do it. But the caveat is the quality of the embryo. So if the embryo, I will always go check with my embryologist. So when we see the embryo report, I'm going to talk to my embryologist and say, what do you think about these embryos? Do you think that they're going to survive the thaw and the biopsy and the refreeze and then the rethaw to transfer? And we'll look at the quality of the embryos, the number of cells in the outer shell of the embryo where we have to do the biopsy from. And if we think that the embryo is not going to make it, then we'll recommend that this is not a good idea. So that this is something that would be very much dependent on the quality of the embryo.
Thank you. And then we have another question here. Are you going to be the doctor in Dallas, and how many years of experience do you have?
Oh gosh, I'm ancient. I started practicing in 2006. I've been in Dallas since 2008. And yes, I will be the doctor in Dallas, and I'm going to have Anissa. She's on this call with us today. She's my physician assistant. So 2 of us are going to tag team to take care of all of our Dallas patients.
Amazing. And it looks like that's all of our questions for today. Thank you all for joining us. We will have a survey at the end of this, so I encourage you all to fill it out, especially those of you who are interested in seeking treatment right away. We will have one of our team members contact you. Thank you all for joining us tonight. And if you have any other questions later down the line, make sure to email us at navigator@kindbody.com or send it to us via DM on Instagram @kindbody. You can also visit our website, kindbody.com, to book an assessment or to learn more. Thank you all for joining us. And thank you, Dr. Mehta, for all this great information that you provided us tonight.
Thank you, everybody. Take care. Have a good evening.
Have a great evening, everyone. Bye-bye.